Abdominal hernias and gastric volvulus de Rohan-Giarajat, Carrie B. Dunbar 27. A hernia is a protrusion of an organ or structure into an opening or pouch. Abdominal wall hernias protrude through the muscular and facial walls of the abdomen and have two parts: 1. The orifice or defect in the aponeurotic wall of the abdomen, and 2. The hernia sac, which consists of peritoneum and abdominal contents. Abdominal wall hernias are external if the sac protrudes through the abdominal wall, or interparietal if the sac is contained within the abdominal wall. Internal hernias are contained within the abdominal cavity and do not always have a hernia sac. Hernias are reducible when the protruding contents can be returned to the abdomen, and irreducible or incarcerated when they cannot. A hernia is strangulated when the vascular supply of the protruding organ is compromised, and as a consequence the organ becomes ischemic or necrotic. An incarcerated hernia is generally repaired because there is danger of strangulation, which can result in the loss of bowel. Because it can be difficult to determine whether a hernia is incarcerated or strangulated, incarcerated hernias are considered urgent and treated with surgical intervention. Another type of hernia is a Richter hernia, where only one side of the bowel, most often the antemesenteric side, protrudes through the hernia orifice. As opposed to other hernias, strangulation may occur in a Richter hernia without intestinal obstruction, making this type of hernia a diagnostic challenge. Diaphragmatic hernias. There are three main types of diaphragmatic hernias: hiatal and paraesophageal hernias. Both involve the hiatus, congenital hernias, and traumatic hernias. Hiatal and paraesophageal hernias. The most common diaphragmatic hernias are sliding hernias of the stomach through the esophageal hiatus, which include hiatal and paraesophageal hernias. Technically, all these hernias are hiatal hernias because they pass through the esophageal hiatus of the diaphragm. These are centrally located hernias. Etiology and pathophysiology. Sliding hiatal hernias, type I, occur when the gastroesophageal junction and some portion of the stomach are displaced above the diaphragm, but the orientation of the stomach axis is unchanged. The frequency of sliding hiatal hernias increases with age. The phrenoesophageal membrane anchors the gastroesophageal junction to the diaphragm. See chapters 43 and 46. Hiatal hernias may be caused by age-related deterioration of this membrane, combined with normal positive intra-abdominal pressure and traction of the esophagus on the stomach as the esophagus shortens during swallowing. 1. Paraesophageal hernias, type 2, occur when the stomach protrudes through the esophageal hiatus alongside the esophagus. Fig. 27.1a. The gastroesophageal junction remains in a normal position at the level of the diaphragm, because there is preservation of the posterior phrenoesophageal ligament and normal anchoring of the gastroesophageal junction, and only the stomach moves proximally. 2. The entire stomach can pass into the chest. See Fig. 27.1b. Most paraesophageal hernias contain a sliding hiatal component in addition to the paraesophageal component and are thus mixed diaphragmatic hernias, type 3. See Fig. 27.1c. Point 3. With a paraesophageal hernia, other intra-abdominal structures, e.g., omentum, colon, spleen, may also herniate, type 4. A barium study is often obtained to diagnose these defects. However, cross-sectional imaging with CT scan will be the test of choice to document a type 4 defect, as the barium study may not reveal adjacent colon or pancreas through the hiatus. When diagnosing a hiatal or paraesophageal hernia, important questions for the radiologist to address include: 1. Does the gastroesophageal junction lie at or above the hiatus? 2. Does the stomach or any other visceral structure lie above the gastroesophageal junction? For example, if the gastroesophageal junction is above the hiatus and there is stomach above it, the patient has a type 3, mixed, hernia. Epidemiology estimates of the prevalence of hiatal hernia vary widely, ranging from 14% to 84% of patients examined, depending on the patient population, method of diagnosis, and symptoms present. 4-8 In general, hiatal hernias are more frequent in patients with GERD. 8 About 90% to 95% of hiatal hernias found by radiograph are sliding, type I, hernias, the remainder are paraesophageal hernias. 3,7 Most sliding hiatal hernias are small and of little clinical significance. Patients with symptomatic paraesophageal hernias are most often middle-aged to older adults. Clinical features, diagnosis, and complications. Many patients with small simple sliding hiatal hernias are asymptomatic. The main clinical significance of the sliding hiatal hernia is its contribution to gastroesophageal reflux. See Chapter 44. In addition to heartburn and regurgitation, patients with large sliding hiatal hernias may complain of dysphagia or discomfort in the chest or upper abdomen. With chest radiography, a hiatal hernia may be noted as a soft tissue density or an air fluid level in the retrocardiac area. Hiatal hernias are sometimes diagnosed on UGI barium studies. CT can demonstrate the proximal stomach above the diaphragmatic hiatus. At endoscopy, the gastroesophageal junction is noted to be proximal to the impression of the diaphragm. Patients with paraesophageal or mixed hiatal hernias are rarely completely asymptomatic if closely questioned. Many patients with paraesophageal hernias have gastroesophageal reflux, particularly those with larger paraesophageal hernias. 3,9 Other symptoms include dysphagia, chest pain, vague postprandial discomfort, and shortness of breath, and some patients will have iron deficiency anemia due to chronic GI blood loss. 9,10 A paraesophageal or mixed hiatal hernia may be seen on a chest radiograph as an abnormal soft tissue density, often with a gas bubble, in the mediastinum or left chest. UGI radiography is the best diagnostic study, see Fig 27.1a. CT scanning can demonstrate that part of the stomach is in the chest. Differences between UGI radiography and CT scan can sometimes be seen, as the latter is performed in the supine position where the stomach may migrate further into the chest. Paraesophageal ABCDE Fig 27.1a, paraesophageal, type 2, hernia. Barium study showing a paraesophageal hernia with a portion of the stomach above the diaphragm. B. This barium study showing a paraesophageal hernia complicated by an organoaxial volvulus of the stomach, see Fig 27.5. The gastroesophageal junction remains in a relatively normal position below the diaphragm, arrow. C. The retroflexed endoscopic view of the proximal stomach demonstrates the endoscope traversing a sliding hiatal hernia adjacent to a large paraesophageal hernia. D. Cameron lesion. A large hiatal hernia is seen on endoscopic retroflexed view, with the Cameron lesion at the level of the diaphragmatic hiatus at the 5 o'clock position. E. Laparoscopic view of a paraesophageal hernia. B. Courtesy Dr. Herbert J. Smith, Dallas, Texas. Chapter 27 Abdominal hernias and gastric volvulus 383 27 hernias are usually obvious on upper endoscopy, see Fig 27.1b, but the paraesophageal component of a large mixed hernia may be missed. Cameron lesions or linear erosions may develop in patients with sliding hiatal hernias, particularly large hernias, see Chapter 20. These mucosal lesions are usually found on the lesser curve of the stomach at the level of the diaphragmatic hiatus, see Fig. 27.1d. This is the location of the rigid anterior margin of the hiatus formed by the central tendon of the diaphragm. Mechanical trauma, ischemia, irritation by pills, and peptic injury have been proposed as the cause of these lesions. The prevalence of Cameron lesions in patients with hiatal hernias who undergo endoscopy has been reported to be about 5%, with the highest prevalence in the largest hernias, with rates of approximately 30% in paraesophageal hernias referred for surgical repair. 11-13 Cameron lesions may cause acute or chronic UGI bleeding with a poor response to acid suppression therapy. 14 Iron deficiency anemia due to chronic bleeding is seen in 30% to 40% of patients with paraesophageal hernia. 9-13 The presence of Cameron lesion, S, and occult GI bleeding is one factor that will influence the surgeon's decision to repair a paraesophageal hernia that is otherwise apparently asymptomatic. Gastric volvulus is a life-threatening complication of paraesophageal hernia. Symptoms include acute abdominal pain and retching, and it can progress rapidly to a surgical emergency, see gastric volvulus. With UGI radiography or CT, lack of filling the gastric lumen with contrast or gastric wall thickening with pneumatoses can increase suspicion for a volvulus and associated gastric necrosis. 15 The diagnosis of gastric volvulus is mostly clinical, and the clinician must have a low threshold to entertain this diagnosis in a patient with a known paraesophageal hernia and new symptoms. Endoscopy may be difficult if the hernia is associated with gastric volvulus, and reaching the pylorus may be a challenge due to positioning of the stomach. 16 Treatment and prognosis. Simple sliding hiatal hernias do not require treatment, unless symptomatic from reflux, see Chapter 46. Patients with symptomatic giant sliding hiatal hernias, paraesophageal, or mixed hernias should be offered surgery. When closely questioned, most patients with type 2, 3, or 4 hernias will have symptoms. 9,10 In the past, all paraesophageal hernias were thought to be a surgical emergency, but it is now clear that the risk of progression to gastric necrosis is lower than initially believed. 17 Elective repair of paraesophageal hernias is more frequently offered to symptomatic patients, although some experts suggest that surgery should be offered to all patients with paraesophageal hernias because of the risk of future complications. 3,9,18,19 In general, a selective approach to patients with large paraesophageal hernias is warranted. Those with symptoms that may be due to the hernia should be considered for surgical intervention, depending on other comorbidities. A careful history is essential for determining the presence of symptoms. One should pay careful attention to chest pain and postprandial shortness of breath. These may be symptoms related to the paraesophageal hernia. Indeed, patients with pulmonary issues may benefit from having their paraesophageal hernias repaired to create room in the chest and decrease aspiration events. The extent of the preoperative evaluation needed for paraesophageal hernia repair is controversial. Patients often have already had a barium esophagogram or other esophageal study that characterizes the paraesophageal hernia. Many surgeons recommend routine preoperative evaluation with esophageal manometry and ambulatory esophageal pH monitoring because of the high prevalence of associated gastroesophageal reflux and esophageal motility disorders, while others may forego pH testing and use reflux symptoms as a guide for the type of repair chosen. 20 The idea behind foregoing pH testing is that the result will not change the surgical management of the patient, who will receive hernia reduction and wrap of some kind anyway. Options for assessment of esophageal pH include 24-hour impedance/pH testing and 48-hour wireless capsule pH monitoring. The object of manometric evaluation is to determine whether the patient has a significant motility disorder, e.g., achalasia, a peristalsis, and what type of fundoplication is needed in patients with reflux symptoms, complete versus partial wrap. However, esophageal manometry is challenging in these patients, and anatomic distortions can make it difficult to identify the lower esophageal sphincter, making this measurement unreliable. 21-24 Patients with dysphagia should be studied to ensure that significantly abnormal motility is not present. Many surgeons routinely add a fundoplication to hernia repairs to prevent postoperative reflux esophagitis and to fix the stomach and the abdomen. However, in patients with motility disorders, the surgeon may elect to perform a loose anterior wrap, door fundoplication, or use a gastrostomy tube or gastropexy to fix the stomach intra-abdominally. The author's practice is to forego motility and pH testing, as the preference is to perform an incomplete wrap of some kind and not a 360-degree wrap that is dependent on good motility. Addition of gastropexy may reduce the recurrence rate after hernia repair. 25-26 The principles of surgery for repair of hiatal or paraesophageal hernias include 4 main elements. 1. Reduction of the hernia from the mediastinum or chest, with excision of the hernia sac. 2. Reconstruction of the diaphragmatic hiatus, with simple posterior closure with or without bolstering with prosthetic mesh. 3. Providing bulk at the hiatus to prevent prolapse into the chest with a fundoplication, which can lessen postoperative reflux, and 4. Addition of a gastropexy or gastrostomy tube to provide an additional tacking mechanism for the stomach intra-abdominally. These elements can be accomplished minimally invasively, laparoscopic or robotically, or via open operation performed through the abdomen or chest. 3,18,27,28 Most patients are approached minimally invasively through the abdomen, which leads to a shorter hospital stay, less postoperative pain, and an equivalent risk of recurrence. See Fig 27.1e. Point 27,28 Reduction of chronic paraesophageal hernias from the chest can be difficult and may be approached through a combined thoracoscopic and abdominal procedure. Injury to the lung can occur with vigorous traction, however, as the diaphragmatic defect is central, medial, rather than peripheral, lateral, as in a traumatic defect, intense lung adhesions are usually not present. Resection of the hernia sac can result in violation of the left chest, requiring chest tube placement. Reconstruction of the diaphragm can be performed by placing non-absorbable sutures posterior to the esophagus. 22,23 Use of prosthetic mesh has resulted in fewer recurrences in some studies. 29,31 The use of mesh is still controversial as there has been no clear long-term results demonstrating a decreased risk of hernia recurrence. However, most surgeons are wary of using synthetic mesh close to the esophagus, and therefore biological products are favored. The shape of the mesh is also an area of controversy. Keyhole mesh can be used, in which the esophagus is completely encircled with mesh, with the concern being dysphagia in this situation. 30-32 Alternatively, U-shaped mesh can be used, where the anterior portion is left open, therefore reinforcing only posteriorly, the major area of recurrence. Fixation of the stomach in the abdomen is usually achieved by using a fundoplication, which provides some bolstering effect at the hiatus to keep the stomach in the abdomen and can reduce postoperative gastroesophageal reflux. Additional use of gastropexy, with suturing of the stomach to the abdominal wall or gastrostomy tube placement for 2 weeks to allow the stomach to mature to the abdominal wall, may result in fewer recurrences. 25 It is the author's preference to perform a door fundoplication, close the diaphragm with keyhole biological mesh, and place a temporary 384 Part 4 Topics involving multiple organs gastrostomy tube, as a pexy, in all patients with large paraesophageal hernias. Patients with sliding hiatal or paraesophageal hernias may have shortening of the esophagus. This makes it difficult to restore the gastroesophageal junction below the diaphragm without tension, a key factor in decreasing recurrence. In such cases, an extra length of neo-esophagus can be constructed from the proximal stomach, Colles-Nielsen procedure. 33 In this situation, a stapler is fired parallel to the axis of the esophagus along a bougie that is passed into the stomach, creating a lengthened esophagus. Alternatively, transmediastinal dissection of the esophagus for more than 5 cm into the chest will usually result in adequate intra-abdominal length of esophagus without the need for additional stapling. 34 In the author's experience, if an adequate transmediastinal dissection is undertaken with excision of the hernia sac, esophageal lengthening is rarely needed. Potential surgical complications include esophageal and gastric perforation, pneumothorax, and liver laceration. Potential long-term complications may include dysphagia if the wrap is too tight or gastroesophageal reflux if the fundoplication breaks down or migrates into the chest. When examined closely, radiographic recurrence after paraesophageal hernia repair is 15% to 25%. 28-35 However, the clinical impact of a recurrence may be minimal because most of these patients remain symptom-free and do not require further treatment. 36 The patient who develops both reflux and dysphagia after paraesophageal hernia repair should be evaluated for a symptomatic recurrence. This is best performed by a UGI barium study. Upper endoscopy can also be helpful and provide dynamic information. The retroflex view from the stomach will demonstrate the presence or absence of a paraesophageal hernia. Recurrence is higher in obese patients and many will favor a Roux-en-Y gastric bypass, RYGB, procedure in those that have a BMI greater than 35 kg/m2. 37-38 Congenital diaphragmatic hernias. Congenital diaphragmatic hernias, CDHs, are rare but can have significant complications. Many are diagnosed at birth. Etiology and pathophysiology. CDHs result from failure of fusion of the multiple developmental components of the diaphragm, Fig 27.2. Embryologically, the diaphragm is derived from the septum transversum, which separates the peritoneal and pericardial spaces, the mesentery of the esophagus, the pleuroperitoneal membranes, and muscle of the chest wall. Morgani hernias form anteriorly at the sternocostal junctions of the diaphragm, and Bokdalic hernias form posterolaterally at the lumbocostal junctions of the diaphragm. 39 Bokdalic hernias most commonly manifest immediately after birth and are commonly associated with pulmonary hypoplasia. Epidemiology: congenital diaphragmatic hernias occur in about January 2000 to 1/10,000 births, with some types seen more frequently in males. 40-43,44 hernias manifesting in neonates are most often Bokdalic hernias. With the routine use of prenatal ultrasound, CDHs can be discovered in the prenatal period. The presence of intra-abdominal contents in the chest during fetal development results in significant hypoplasia of the lung. It is the degree of pulmonary dysfunction, not the presence of the hernia per se, that determines the child's prognosis. Prenatal measures are then taken to prepare for the pulmonary hypoplasia that invariably accompanies a large CDH. Only a few Bokdalic hernias are first discovered in adulthood. 45 Bokdalic hernias occur on the left side in about 80% of cases, Fig 27.3. 46-48 Right-sided Bokdalic hernias usually contain liver in the right chest. Morgani hernias make up about 2% to 3% of surgically treated diaphragmatic hernias, Fig 27.4, 49,50. Although thought to be congenital, they usually manifest in adults and occur on the right side in 80% to 90% of cases. 49 Clinical features, diagnosis, and complications. The clinical presentation of congenital diaphragmatic hernias varies greatly, from death in the neonatal period to an asymptomatic serendipitous finding in adults. Newborns with Bokdalic hernia have respiratory distress, absent breath sounds on one side of the chest, and a scaphoid abdomen. 51 Serious chromosomal anomalies are found in 30% of cases, but in many cases the exact mutation, or mutations, cannot be identified. 52 Pulmonary hypoplasia occurs on the side of the hernia, but some degree of hypoplasia may also occur in the contralateral lung. Pulmonary hypertension is common. The major causes of mortality in infants with Bokdalic hernias are respiratory failure and associated anomalies, which can include cardiac abnormalities and musculoskeletal defects. 51 Most of these neonates are diagnosed in utero with routine use of prenatal ultrasound, which visualizes stomach or loops of bowel in the chest. The pregnancy is considered high risk when congenital diaphragmatic hernia is diagnosed in the prenatal period. These babies are delivered electively and preparations are made for immediate extracorporeal membrane oxygenation, ECMO. In older children and adults, a Bokdalic hernia may manifest as an asymptomatic chest mass. The differential diagnosis includes mediastinal or pulmonary cyst or tumor, pleural effusion, or empyema. Symptoms, when present, can include pain, pulmonary symptoms, and obstructive symptoms and are due to herniation of the stomach, omentum, colon, or small bowel. 48 About 30% of adult patients present with acute emergencies caused by strangulation, and gastric volvulus can occur. 48 Other patients may have chronic intermittent symptoms, including chest discomfort, shortness of breath, dysphagia, nausea, vomiting, and constipation. The diagnosis may be suspected on a chest radiograph, particularly a lateral view. The key finding is a posterior chest mass, as the defect of Bokdalic is posterior. The diagnosis may be confirmed by barium UGI radiography, useful if only the stomach is involved, CT, or MRI. 40,48 Morgani hernias are most likely to manifest in adult life. They may contain omentum, stomach, colon, or liver. Bowel sounds may be heard in the chest if bowel has herniated through the defect. As with Bokdalic hernias, the diagnosis is often 11233. Fig 27.2 Congenital diaphragmatic hernias. Diagram of the diaphragm viewed from below with areas of potential herniation shown. 1. Sternocostal foramina of Morgani anteriorly. 2. Esophageal hiatus. 3. Lumbocostal foramina of Bokdalic posteriorly. Arrows indicate the direction of herniation. 27AB Fig 27.3 Bokdalic hernia. A. This plain chest film shows a Bokdalic hernia as a small opacity in the posterior chest at the level of the diaphragm, with bowel in the left chest, arrows. B. CT of the same patient showing bowel above the diaphragm and causing a mediastinal shift. Fig 27.4 Morgani hernia. A mass is noted in the right chest on a chest film, postero-anterior view. B. Lateral chest film shows that the mass is in the anterior chest. C. Barium enema shows that a portion of the transverse colon is the hernia, top left. D. CT shows a contrast-filled colon in the right anterior chest, 11 o'clock position. ACDB 386 Part 4 Topics involving multiple organs made by chest radiography, particularly the lateral view, because Morgani hernias are anterior, differentiating this hernia from a Bokdalic defect, see Fig 27.4. The contents of the hernia can be confirmed with barium radiography or CT, see Fig 27.3a and b and Fig 27.4 c and d. The differential diagnosis is similar to that of Bokdalic hernias. Many patients have no symptoms or nonspecific symptoms such as chest discomfort, cough, dyspnea, and upper abdominal distress. Gastric, omental, or intestinal incarceration with obstruction and ischemia may cause acute symptoms. 49,50 Treatment and prognosis for infants with Bokdalic hernias, intubation and mechanical ventilation are often needed at the time of delivery. ECMO is useful in some cases with cardiac dysfunction and pulmonary hypertension. 51 Once the infant's pulmonary issues have stabilized, surgical repair is performed, either open or laparoscopic, using a mesh prosthesis. Despite advances in critical care and surgical techniques, the mortality rate is still around 60%, although higher survival rates have been reported by some centers. 51 The abdomen may not be able to tolerate the increased pressure when the intestinal contents are reduced, and therefore a gradual abdominal closure, silo technique, can also be used. 53 Laparoscopic and thoracoscopic repair of Bokdalic hernias have been reported. 48,54 Morgani hernias have been repaired through the chest or abdomen, using open, thoracoscopic, and / or laparoscopic techniques. 49,50 An abdominal laparoscopic approach is favored in small diaphragmatic hernias. One must be careful to note the inferior epigastric vessels that are present in the location of the Morgani hernia. This anterior defect can be bridged with synthetic mesh. Larger Bokdalic defects require open approach with use of prosthetic mesh. Traumatic and post-traumatic diaphragmatic hernias. Etiology and pathogenesis. Traumatic diaphragmatic hernias are caused by blunt trauma such as motor vehicle accidents in about 75% of cases, and by penetrating trauma such as stab or gunshot wounds in the remainder. 55 During blunt trauma, abrupt changes in intra-abdominal pressure may lead to large rents in the diaphragm. A huge impact is needed to cause a diaphragmatic injury. As such, associated injuries are commonly life-threatening in the circumstance of a blunt diaphragmatic injury. Penetrating injuries often cause only small lacerations. Blunt trauma is more likely than penetrating trauma to eventually lead to herniation of abdominal contents into the chest, because the defect is usually larger. The right hemidiaphragm is somewhat protected by the liver during blunt trauma. Thus, in one series, 68% of diaphragmatic injuries from blunt trauma occurred on the left side, 24% on the right side, 1.5% were bilateral, 1% pericardial, and 5% unclassified. 55 Diaphragmatic injury may not result in immediate herniation, but with time, normal relative negative intrathoracic pressure may lead to gradual enlargement of a small diaphragmatic defect and protrusion of abdominal contents through the defect, leading to a delayed diagnosis in about 15% of cases. 56 Stomach, omentum, colon, small bowel, spleen, and even kidney may be found in a post-traumatic diaphragmatic hernia. Epidemiology. The incidence of post-traumatic diaphragmatic hernia is uncertain. Diaphragmatic injury occurs in about 5% of patients with multiple traumatic injuries who undergo laparotomy and was found in approximately 1% of patients in a large trauma database. 57,58 Clinical features, diagnosis, and complications. Post-traumatic diaphragmatic hernias may cause respiratory or abdominal symptoms. After serious trauma, rupture of the diaphragm is often masked by other injuries. 59 Penetrating injuries between the fourth intercostal space and the umbilicus should raise the level of suspicion of a diaphragmatic injury. Respiratory or abdominal symptoms manifesting several days to weeks after injury should suggest the possibility of a missed diaphragmatic injury. The diaphragm must be closely inspected to detect injury at the time of exploratory laparotomy or laparoscopy, as these injuries can easily be missed. Careful examination of the chest radiograph or CT is important but is diagnostic in only 40% to 80% of cases, depending on the type of CT performed. 60 The coronal and sagittal reconstructions can show the defect in the diaphragm. In patients on ventilatory support after trauma, positive intrathoracic pressure may prevent herniation through a diaphragmatic tear. However, on attempted ventilator weaning, herniation may occur, causing respiratory compromise. Symptoms may also manifest long after injury. Delays of more than 10 years have been reported. 56 In such cases, the patient may not connect the acute illness with remote trauma. The treating physician should consider a traumatic cause when a diaphragmatic defect is not hiatal and is not located in the usual locations of congenital defects. Treatment and prognosis. Acute diaphragmatic ruptures are most commonly approached from the abdomen during exploratory laparotomy or laparoscopy. Associated intra-abdominal injuries that can be life-threatening must be ruled out in these cases. However, a chest approach can be undertaken. Diagnostic laparoscopy has been used in patients who are thought to have a high risk of diaphragmatic injury, but appear to have no other visceral injury, e.g., after a stab wound to the lower chest. 61 Chronic post-traumatic diaphragmatic hernias are characterized by a lack of a peritoneal lining, or hernia sac. As such, these hernias are commonly associated with extensive adhesions to adjacent lung, reduction of which can cause significant bleeding. In such cases, repair is best performed through the chest or by a combined thoracoscopic abdominal approach, although laparoscopic or thoracoscopic repair has been reported. 61 A combined thoracoscopic abdominal approach lowers the risk of lacerating the lung if adhesions and absence of a peritoneal hernia sac complicate the abdominal approach. Gastric volvulus. Gastric volvulus results when the stomach twists on itself, but rarely occurs unless there is an associated diaphragmatic hernia. Pear described the first case of gastric volvulus in 1579 in a patient who had a diaphragmatic injury from a sword wound. Gastric volvulus may be transient and produce few symptoms, or it may lead to obstruction and ischemia. Etiology and pathophysiology. The stomach is normally fixed in position by ligamentous attachments to the spleen, liver, and diaphragm. When there is normal intestinal rotation, the duodenum is fixed to the retroperitoneum, which results in pexy of the distal stomach. Laxity of these ligamentous attachments, elevation of the left hemidiaphragm, or fixation of an otherwise mobile stomach to a specific point can result in volvulus. Focal adhesions, gastric tumor, or masses in adjacent organs may predispose to gastric volvulus. In 2/3 of cases, the volvulus occurs above the diaphragm in association with a paraesophageal or mixed diaphragmatic hernia. In the other third of cases, volvulus occurs below the diaphragm. Chapter 27 Abdominal hernias and gastric volvulus. 387 27 Gastric volvulus may be mesenteroaxial or organoaxial, Fig. 27.5.62 In mesenteroaxial volvulus, the stomach folds on its short axis, which runs across the stomach from the lesser curvature to the greater curvature, see Fig. 27.5, 1a and 1b, with the antrum twisting anteriorly and superiorly. In rare cases, the antrum and pylorus rotate posteriorly. Mesenteroaxial volvulus is often incomplete and intermittent, manifesting chronic symptoms. In organoaxial volvulus, the stomach twists along its long axis, which passes through the esophagastric junction region to the pylorus. In most cases, the antrum rotates anteriorly and superiorly and the fundus posteriorly and inferiorly, twisting the greater curvature at some point along its length, see Fig 27.5, 3a and 3b. Less commonly, the long axis passes through the body of the stomach itself, in which case the greater curvature of the antrum and fundus rotate anteriorly and superiorly, see Fig 27.5, 2a and 2b. This type of volvulus is commonly associated with a diaphragmatic hernia. Organoaxial volvulus is usually an acute event. Mixed mesenteroaxial and organoaxial volvulus has also been reported. 63 Epidemiology. The incidence and prevalence of gastric volvulus are unknown. It is difficult to estimate how many cases are intermittent and undiagnosed. About 15% to 20% of cases occur in children younger than 1 year of age, most often in association with a congenital diaphragmatic defect. The peak incidence in adults is in the 5th decade. Men and women are equally affected. 64,65 Clinical features, diagnosis, and complications. Acute gastric volvulus causes sudden severe pain in the upper abdomen or lower chest, associated with the inability to swallow. Persistent unproductive retching is common. In cases of complete volvulus, it is impossible to pass a nasogastric tube into the stomach. Hematemesis is rare but may be due to an esophageal tear or gastric mucosal ischemia. 65 Vascular compromise and gastric infarction may occur. The combination of pain, unproductive retching, and inability to pass a nasogastric tube is called Borchardt triad. 66 If the volvulus is associated with a diaphragmatic hernia, plain chest or abdominal films will show a large gas-filled structure in the chest. 15 CT is often obtained in the emergency department and will show the stomach in the chest. A barium UGI radiograph will confirm the diagnosis but is often unnecessary in the case of the classic triad, and diagnostic CT upper endoscopy may show twisting of the gastric folds. Fig 27.6c. Acute gastric volvulus is a surgical emergency. The surgeon must have a low threshold for making this diagnosis in a patient that presents with this symptom complex. Delay in surgery can result in gastric necrosis, which has a high mortality. Chronic gastric volvulus is associated with mild and nonspecific symptoms like dysphagia, epigastric discomfort or fullness, bloating, and heartburn, particularly after meals. Symptoms may be intermittent and present for months to years. 65 A substantial number of cases likely go unrecognized. The diagnosis should be suspected in the proper clinical setting if a UGI radiograph or CT shows a large diaphragmatic hernia, even if the stomach is not twisted at the time of the radiograph. 15 Treatment and prognosis. Acute gastric volvulus is an emergency, with a mortality rate in the vicinity of 30%. 62 Nasogastric decompression should be performed if possible. If signs of gastric infarction are not present, acute endoscopic detorsion may be considered. Using fluoroscopy, the endoscope is advanced to form an alpha loop in the proximal stomach. 67 The tip is passed through the area of torsion into the antrum or duodenum if possible, avoiding excess pressure. Torque may then reduce the gastric volvulus. This technique is most often used in chronic gastric volvulus without signs of ischemia. 67,68 Definitive surgical intervention should not be delayed for endoscopy. Surgery for gastric volvulus may be performed by open or minimally invasive techniques. In recent years, minimally invasive repair has become the gold standard for repair of chronic volvulus. Insufflation of the abdomen may not be hemodynamically tolerated in a critically ill patient. In this circumstance, acute torsion should be repaired open. 64,65 After the torsion is reduced, the stomach is fixed by gastropexy or tube gastrostomy. Associated diaphragmatic hernia must be repaired. 65,69 However, in the circumstance of a critically ill patient, the surgeon may elect to place a gastrostomy tube and later return to the operating room to complete the other components of the repair, as noted earlier. Combined endoscopic and laparoscopic repair or simple endoscopic gastropexy by placement of a percutaneous gastrostomy tube has been reported. 69-71,72 Chronic gastric volvulus is treated in the same manner as acute volvulus. If the patient is clinically stable, the surgeon may elect to treat the underlying cause of the volvulus, e.g., associated paraesophageal hernia, in the usual manner, with repair of the diaphragm and fundoplication. It is unusual to have a gastric volvulus in the absence of an associated paraesophageal hernia. 123AB Fig 27.5 Pathogenesis of gastric volvulus. 1a. Axis for potential mesenteroaxial volvulus bisecting the lesser and greater curvatures. 1b. Mesenteroaxial volvulus resulting from anterior rotation of the antrum along this axis. 2a. Axis for potential organoaxial volvulus passing through the body of the stomach. 2b. Organoaxial volvulus resulting from anterior superior rotation of the antrum along this axis. 3a. Axis for potential organoaxial volvulus passing through the gastroesophageal junction and the pylorus. 3b. Organoaxial volvulus resulting from anterior superior rotation of the antrum and posterior inferior rotation of the fundus along this axis. Adapted from Carter R., Brewer L.A. 3rd, Hinshaw D.B. Acute gastric volvulus. A study of 25 cases. AMJSURG 1980, 140:1016. 388 Part 4 Topics involving multiple organs: inguinal and femoral hernias, etiology and pathophysiology. The abdominal wall is protected from hernia formation by several mechanisms. In the lateral abdominal wall, there are layers of muscles that together with intervening fascia provide support. These muscles travel at oblique angles to each other and therefore handle forces in various planes, affording greater support than if they were parallel to each other. In the central abdomen, the bulky rectus abdominis muscles provide a barrier to herniation. Abdominal wall hernias occur in areas where these muscles and fascial layers are attenuated, and the hernias can be congenital or acquired. In the groin, an area prone to herniation is bounded by the rectus abdominis muscle medially, the inguinal ligament laterally, and the pubic ramus inferiorly. The aponeurosis of the transversus abdominis muscle provides the deep layer. In this area, the external and internal oblique muscles thin to a facial aponeurosis only, so there is no muscular support of the transverse abdominal fascia and the peritoneum. Upright posture causes intra-abdominal pressure to be constantly directed to this area. During transient increases in abdominal pressure, e.g., coughing, straining, heavy lifting, reflex abdominal muscle wall contraction narrows the myopectoneal orifice and tenses the overlying fascia. Shutter mechanism. 73 Chronic cough, smoking, increasing age, and male gender are thus associated with an increased risk of hernia. 74,75 During embryologic development, the spermatic cord and testis in men, the round ligament in women, migrate from the retroperitoneum through the anterior abdominal wall to the inguinal canal, along with a projection of peritoneum, processus vaginalis. The defect in the abdominal wall, internal inguinal ring, associated with this process represents an area of potential weakness through which an indirect inguinal hernia may form. Fig 27.7. The processus vaginalis may persist in 12% to 20% of adults, further predisposing to hernia formation. 76 Direct inguinal hernias do not pass through the internal inguinal ring but rather protrude through defects in an area called Hesselbach triangle, bounded medially by the rectus abdominis muscle, laterally by the inferior epigastric artery, and inferiorly by the inguinal ligament. See Fig 27.7. Therefore, indirect inguinal hernias travel with the spermatic cord, or round ligament, and are found lateral to the inferior epigastric vessels, whereas direct hernias are found in the floor of the inguinal canal, an area supported only by the weak transversalis fascia, and are medial to the inferior epigastric vessels. Femoral hernias pass through the opening associated with the femoral artery and vein. They manifest inferior to the inguinal ligament and medial to the femoral artery. See Fig 27.7. 73 Clinical examination cannot easily differentiate indirect from direct inguinal hernias. The importance of distinguishing these two entities preoperatively is not critical, because the operative approach and repair are identical. However, it is important to accurately diagnose femoral hernias because they can be mistaken for lymph nodes in the groin. Misinterpreting an incarcerated loop of bowel in a femoral defect as a lymph node can lead to fine needle aspiration of the mass and bowel injury. Any mass that is medial to the femoral arterial pulsation and inferior to the inguinal ligament should be evaluated for a femoral hernia. The omentum, colon, small bowel, and bladder are the most common contents of groin hernias, although the appendix, mechal diverticulum, fallopian tube, and ovary have been reported to herniate. 77-82 in a Richter hernia, only the antimesenteric side of the bowel protrudes. In this situation, the patient can have strangulation of the bowel without evidence of bowel obstruction, which is typically present when bowel is incarcerated in a hernia. The surgeon must be wary of the Richter hernia, as ABGEC Fig 27.6 gastric volvulus with paraesophageal hernia. A. Chest film showing a gas-filled mediastinal mass. B. Barium examination showing that the greater curvature and lesser curvature of the stomach are reversed in position, upside-down stomach. C. Twisting of the gastric folds at the point of torsion is noted in this endoscopic view of a gastric volvulus. A. Courtesy Dr. Mark Feldman, Dallas, Texas. Chapter 27 Abdominal hernias and gastric volvulus 389-27 This can result in intestinal necrosis, despite the lack of the typical association with a bowel obstruction. Epidemiology: the lifetime risk of groin hernia requiring repair is 27% for men and 3% for women, with repair seen most often in children under age 5 and adults older than 70.83,84. The incidence increases with age, from 1% in men younger than age 45 to 3% to 5% in those older than 45. About 800,000 groin hernia repairs are performed annually in the USA. 85 of these, 80% to 90% are performed in men. 83,86 Indirect inguinal hernias account for about 65% to 70% of groin hernias in men and women. In men, direct inguinal hernias account for about 30% and femoral hernias for about 1%. In women, about 25% of groin hernias requiring repair are femoral, and the occurrence increases with age. 83,86 Groin hernias are somewhat more common on the right than on the left side. Congenital hernias are more common in males because they represent a patent processus vaginalis. These pediatric hernias are commonly bilateral, and pediatric surgeons are taught to always evaluate the contralateral side. Clinical features, diagnosis, and complications: many groin hernias are asymptomatic. The most common symptom is a mass in the inguinal or femoral area that enlarges when the patient stands or strains. An incarcerated hernia may produce constant discomfort. Strangulation causes increasing pain. Symptoms of bowel obstruction or ischemia may occur. In a Richter-type hernia, pain from bowel strangulation may occur without symptoms of obstruction, as only one wall of the intestine is involved in the hernia. The patient should be questioned about risk factors for hernia formation, e.g., smokers with a chronic cough, prostatism, constipation. These factors, if not corrected prior to herniorrhaphy, can lead to recurrence. 87,88 On physical examination, inguinal hernias present as a soft mass in the groin. The mass may be larger on standing or straining. It may be slightly tender. It may be possible to palpate the facial defect associated with the hernia. The patient should be examined upright, the examiner's finger should be inserted into the inguinal canal, and a prolonged Valsalva maneuver should be initiated. It is normal to feel a small impulse against the examining finger with coughing. However, when a hernia is present, a prolonged Valsalva maneuver will result in protrusion of the sac, which is tender against the examiner's finger. Direct and indirect hernias may be difficult to distinguish. Groin hernias may also be noted on a plain abdominal radiograph, Fig 27.8, barium radiograph, sonogram, or CT. An MRI may be helpful for identifying other causes of groin pain. 89 Femoral hernias are more difficult to diagnose than other groin hernias, and 30% to 40% manifest as surgical emergencies due to strangulation. 74,86 The correct diagnosis is often not made before surgery. The neck of femoral hernias is usually small. Even a small femoral hernia that is difficult to palpate may cause obstruction or strangulation. Richter hernias are most common in the femoral area, further complicating the diagnosis. Femoral hernias are most common in women, in whom clinicians may have a lower level of suspicion for hernia than in men. Femoral hernias also occur in children. 90 Delay in diagnosis, strangulation, and need for emergency surgery are common. 86, 91 Any mass below the inguinal ligament and medial to the femoral artery should raise the suspicion of femoral hernia. Femoral hernias are commonly mistaken for femoral adenopathy or groin abscess. 91 Obviously, bedside incision and drainage of an incarcerated femoral hernia must be avoided, and therefore liberal use of sonography or CT is useful for distinguishing a hernia from adenopathy. Indirect inguinal hernia, Spigelian hernia, external oblique inguinal ligament, internal inguinal ring, femoral artery, femoral vein, spermatic cord, direct inguinal hernia, femoral hernia. Fig 27.7 Anatomic diagram of Spigelian hernia, indirect and direct inguinal hernias, and femoral hernia. The external oblique muscle has been omitted, and the spermatic cord, the round ligament in women, is retracted. Spigelian hernia occurs through defects in the fused aponeurosis of the internal oblique and transverse abdominal muscles. Indirect inguinal hernia occurs through the internal inguinal ring. Direct inguinal hernia occurs through defects in the transversalis fascia in Hesselbach triangle. Femoral hernia occurs inferior to the inguinal ligament and medial to the femoral vein and femoral artery. Fig 27.8 Plain film in a 28-year-old man with a giant incarcerated inguinal hernia. Courtesy Dr. Michael J. Smarud, Dallas, Texas. 390 Part 4 Topics involving multiple organs, abscess, or other masses. 89 The radiologist should perform these examinations with and without a prolonged Valsalva maneuver to demonstrate small defects. Treatment and prognosis. Many surgeons recommend repair of direct and indirect inguinal hernias even if they are asymptomatic, but this is controversial. A study by the American College of Surgeons has shown that males with minimally symptomatic groin hernias can be safely watched. 92 This study randomized 720 male patients to elective hernia repair or watchful waiting. Only 2 of the 364 patients in the watchful waiting arm of the study developed complications related to their hernia in 4.5 years. This suggests that minimally symptomatic patients can be watched safely and have their hernia repaired when symptoms increase. 93 Femoral hernias must be repaired promptly because the risk of strangulation is higher. 79, 84 When a patient presents with an incarcerated hernia and does not have clear signs and symptoms of ischemic bowel, it is reasonable to try to reduce the hernia manually. This will convert an emergent surgery into a semi-elective one. The patient can be sedated and placed in Trendelenburg position. 2 hands must be used to coax the hernia back through the hernia defect. The patient must be watched closely to ensure dead bowel has not been reduced into the peritoneal cavity, a situation that can cause peritonitis and death. It is the author's experience that ischemic bowel is so edematous that manual reduction is usually not possible. Repair of the hernia should occur within that same hospitalization, unless there are medical issues that justify a delay, e.g., recent acute myocardial infarction. Groin hernias can be repaired using various techniques, including open or minimally invasively, with or without mesh, and are a source of ongoing debate for surgeons. Historically, tissue repairs have been performed. However, several studies have shown a decreased recurrence rate with the use of mesh, resulting in tension-free repairs, both for open and laparoscopic repairs. 94-97 Use of mesh is considered standard of care in the current era of hernia repair. The traditional tissue-based repairs were performed exclusively until the 1990s. There are 2 key components to successful hernia repair: 1. High ligation of the hernia sac, which treats the direct defect, and 2. Repair of the floor of the canal, which treats the indirect defect. Even if there is no direct component, a repair of the floor is routinely undertaken. These repairs involve approach to the inguinal canal through a small incision parallel to the inguinal ligament and centered over the internal inguinal ring. Dissection is continued through the external oblique muscle, exposing the internal inguinal ring. The cord structures are then isolated and explored thoroughly to identify an indirect hernia sac, which is ligated and transected. The floor of Hesselbach triangle is then reinforced and strengthened by opposing the lateral border of the rectus abdominis aponeurosis to the inguinal ligament. Bassini or Scholdi's repair, or to Cooper ligament, McVeigh repair. 98-100 Tissue repairs inherently are not tension-free and pose a greater risk of recurrence than tension-free mesh repairs. Use of mesh is considered the gold standard in elective hernia repair. 85 However, in cases where there is probable contamination, e.g., in a strangulated hernia, it is important to perform a primary tissue repair and not a mesh repair, because there is a high risk of mesh infection. Open mesh repairs are most commonly performed as described by Lichtenstein. 97,101 These can be performed under local, regional, or general anesthetic. 102,103 The major components of successful repair begin with high ligation of the sac, but the floor is repaired using synthetic mesh to bridge the gap between the conjoint tendon, edge of the rectus aponeurosis, and inguinal ligament, thus reconstructing the floor of the canal. The mesh can be sutured or stapled in place. Mesh plug repairs have also been developed and appear to have outcomes similar to other repairs. 104 In these cases, minimal dissection is undertaken, and the mesh plug, which looks like a badminton shuttlecock, is laid into the defect and tacked in place with a few sutures. The mesh causes fibroblast ingrowth and scarring that leads to strengthening of the floor of the inguinal canal. Mesh repairs have the advantage of being somewhat simpler to perform than tissue repairs and have less tension, less acute pain, and a decreased rate of recurrence. 94,95,96 Bilateral, very large, or complex abdominal hernias can be repaired with a large mesh that reinforces the entire ventral abdominal wall. This is called giant prosthetic reinforcement of the visceral sac, GPRVS, or the STOPA procedure. 105 Several series have compared open hernia repair with laparoscopic repair. The largest and most recent study was performed by the Veterans Cooperative Group. 106 Almost 1,700 patients were followed for 2 years after being randomized to open versus laparoscopic repair of inguinal hernias. Patients who had their hernias repaired laparoscopic had less pain initially and returned to work 1 day sooner than those who had open repair. However, the recurrence rate was higher in the laparoscopic group, 10% versus 4% in the open group, and complication rates were higher and more serious in the laparoscopic group than in the open repair group. Meta-analyses of open versus laparoscopic repair have suggested that laparoscopic repair causes less pain, but recurrence rate is higher, as is the risk of complications. 107,108,109 Results of the Veterans Cooperative Group trial and other studies have changed the face of hernia repair in the USA. Patients with primary groin hernias are treated with open mesh repair unless they have a strong preference for a laparoscopic approach. Those with recurrent or bilateral hernias can be considered for laparoscopic repair, which can be performed effectively in experienced hands. Minimally invasive hernia repair can be performed via a totally extraperitoneal (TEP) approach or transabdominal preperitoneal approach (TAP). 110-112 In the former case, the dissection is performed just above the peritoneum using a balloon for dissection. The mesh is then placed in this plane. In the TAP procedure, the abdomen is entered and a peritoneal flap is raised. The mesh is placed and the flap is reattached to prevent the mesh from being in contact with bowel. The TAP approach can cause intra-abdominal adhesions and future risk for adhesive bowel obstruction, a downside to this approach. The robotic approach utilizes the TAP technique. Post-surgery complications and recurrence. Elective groin hernia repair is safe, and serious complications are unusual. 106-108 Lacerations of the bowel, bladder, or blood vessels may occur, particularly during a TAP repair, and may cause serious consequences if not detected early. Damage to the bowel may also occur during reduction of an incarcerated hernia. Minor acute complications include acute urinary retention, seroma, hematoma, and infection. 92,104,113 Serious infection occurs in less than 1% of cases. Damage to the spermatic cord may lead to ischemic orchitis. 92 Tissue dissection predisposes to thrombosis of the venous drainage of the testis. Symptoms are swelling and pain of the cord and testis. The condition persists for 6 to 12 weeks and may result in testicular atrophy. Fortunately, this is a rare complication, occurring after about 0.04% of tissue repairs. 114,115 hydrocele or vas deferens injury occurs in less than 1% of cases. 115 damage to sensory nerves is not uncommon during inguinal hernia surgery, and can be related to the division or preservation of the ilioinguinal nerve as it traverses the inguinal canal. 116-118 Chronic paresthesias and pain of the medial aspect of the scrotum are reported by about 10% of patients, either caused by damage to the sensory nerves or neuroma. This can be treated by local nerve block, desensitization therapy, and neurectomy. 118-120 Chapter 27 Abdominal hernias and gastric volvulus 391-27 Some recurrent hernias are actually indirect hernias missed during the first hernia repair. The risk of recurrence is related to conditions that lead to tissue deterioration, such as malnutrition, liver or renal failure, glucocorticoid therapy, and malignancies. 121 Patients with scrotal hernias and recurrent hernias are at higher risk for recurrence or recurrence, respectively. 88 Recurrent hernias are also more common among smokers than non-smokers. 75 In patients with cirrhosis and no ascites or moderate ascites, inguinal hernia repair is reported to be safe, although the recurrence rate is increased in some series. 122,123 Ideally, the ascites is aggressively controlled prior to elective herniorrhaphy, and a TIPS or liver transplantation should be considered. As mentioned, recurrence rates are higher with laparoscopic hernia repair than with open herniorrhaphy. 106-108 Routine use of mesh has reduced recurrences, because the learning curve for open mesh repair is quicker than for laparoscopic or tissue repair. Overall, recurrence rates are higher after tissue repairs than after tension-free mesh repairs. 95,108 For inguinal hernias, the most favorable reported recurrence rates for Canadian and Cooper ligament repairs have been about 1.5% to 2% for primary repairs and about 3% for repair of recurrent hernia. 98,100 Reported recurrence rates for mesh repairs vary from 0% to 4% for primary repairs, and use of mesh appears to reduce recurrence. 94,106,108 Inguinal hernias and colorectal cancer screening. Some practitioners recommend that patients aged 50 years or older with inguinal hernias be screened for colorectal neoplasms before hernia repair. One older prospective study using flexible sigmoidoscopy to screen primarily middle-aged or elderly men with inguinal hernias reported the prevalence of colorectal polyps to be 26% and the prevalence of colorectal cancers to be 3.6%. 124 However, more recent data have clearly shown that there is no increased risk of colorectal cancer in patients who have groin hernias. In a prospective study of colonoscopy for screening of asymptomatic U.S. veterans, the prevalence of polyps was 37.5% and of colorectal cancer 1%. 125 Thus, the prevalence of colorectal neoplasms is substantial in middle-aged or older men with or without inguinal hernias. In several more recent studies, the risk of colorectal cancer was found to be similar in patients with hernias, 5%, compared with a control group that did not have hernias, 4%. 126 Large inguinal hernias, particularly incarcerated hernias, may cause difficulty during sigmoidoscopy or colonoscopy. In such patients, it may be advisable to defer the examination until after hernia repair. Incarceration of colonoscopes within hernias has been reported. 127 Inguinal hernias and benign prostatic hyperplasia. Inguinal hernia and symptomatic benign prostatic hyperplasia commonly occur in older men. 128 Straining to void may cause worsening of inguinal hernia. Conversely, the risk of postoperative urinary retention after hernia repair is increased by prostatic hyperplasia, and older male patients with any symptoms of prostate disease should be counseled on the risk of urinary retention after hernia repair. 128 With the advent of improved medical therapy for benign prostatic hyperplasia, most patients can be managed with medical therapy prior to herniorrhaphy. It is important that the prostatism is dealt with medically prior to elective hernia repair. This will avoid urinary retention postoperatively that can be painful and extend length of stay. If elective inguinal hernia repair and transurethral prostatic resection are required, some surgeons would consider performing these procedures concurrently. 129,130 But more frequently, concerns about infection of mesh lead to sequential surgery. Other ventral hernias. True ventral hernias include incisional, epigastric, umbilical, and spigelian hernias. Patients often mistake diastasis recti for ventral hernia. Diastasis recti is a separation of the rectus abdominis muscles without a defect in the abdominal fascia and can be demonstrated as a midline defect exaggerated by a Valsalva maneuver. No facial ring can be palpated, and the defect is often very wide and long. This condition does not require repair and is cosmetic only. Incisional hernias. Incisional hernias, as the name implies, are hernias that occur after a prior operation. Incisional hernias include post-laparotomy hernias, peristomal hernias, and trocar site hernias. Etiology and pathophysiology. Incisional hernias are caused by patient and surgery-related factors. The former includes conditions that may increase intra-abdominal pressure, e.g., obesity, collagen vascular diseases, a history of surgically repaired aorta, nutritional factors, ascites. 123,131-133 conditions that impair healing, such as collagen vascular disease in patients receiving glucocorticoid therapy and smoking, can also increase postoperative hernia formation. 134 Surgery-related factors include the type and location of the incision. It is more common for hernias to develop after a vertical midline incision than after a transverse incision. 135 This has led some surgeons to use transverse incisions in patients who are predisposed to hernias, such as patients with Crohn's disease who are receiving glucocorticoids or other immunosuppressants. Development of a postoperative wound infection can lead to a higher incidence of hernia formation. 135 Placement of a stoma results in an intentional creation of a hernia through which the intestine runs. By placing these intentional hernias within the rectus muscle rather than lateral to the rectus, or by using mesh to reinforce the area, the risk of peristomal hernia can be decreased. 136 Trocar site hernias have become a more common occurrence with the increased use of minimally invasive surgery. The rate of hernia formation is related to the size of the trocar used. Trocars 10 mm in diameter are more commonly associated with hernia formation, length of surgery, obesity, and advancing age. 137 Lateral trocar placement has a lower chance of hernia formation than midline placement. Epidemiology. Incisional hernias are common after laparotomy. When followed carefully over a long period, up to 20% of patients can be found to develop a hernia. This incidence increases to 35% to 50% of cases when there is wound infection or dehiscence. 138,139 Up to 50% of such hernias manifest more than 1 year after surgery. 138 Vertical incisions, as compared with transverse incisions, obesity, advanced age, diabetes, sepsis, postoperative pulmonary complications, immunosuppression, and glucocorticoid use increase the risk. 135 Peristomal hernias are reported to occur in as many as 50% of cases after stoma placement. 136 Specific measures are taken at the time of surgery to decrease the incidence of hernia formation. For example, the smallest facial defect is created within the rectus sheath, rather than lateral to it. The use of biological mesh in primary stoma placement may reduce the incidence of subsequent hernia formation, but this routine use of mesh is controversial, and a multi-center randomized controlled trial is planned to address this. 136,140 Conditions that lead to bowel dilation prior to stoma placement, e.g., obstruction, can result in subsequent 392 Part 4 Topics involving multiple organs. Bowel shrinkage after stoma placement. This shrinkage can increase the space between the bowel wall and fascia, facilitating hernia formation. Trocar site hernias are estimated to occur after 0.5% of laparoscopic cholecystectomies. 137 They usually occur at the site of the largest trocar, which is typically larger than 10 mm in diameter and is at the umbilical location. Clinical features, diagnosis, and complications. Incisional hernias can cause chronic abdominal discomfort. Because the facial defect of incisional hernias is usually large, strangulation is unusual even with incarceration. Reduced ability to voluntarily increase intra-abdominal pressure interferes with defecation and urination. Lordosis and back pain may occur, due to decrease in a balanced core. 139 Large incisional hernias may lead to event ration disease. With the loss of integrity of the abdominal wall, the diaphragm cannot contract against the abdominal viscera during inspiration, but rather forces the viscera into the hernia. The diaphragm thus becomes inefficient, and the hernia tends to enlarge. The viscera may lose the so-called right of domain in the abdominal cavity. Surgeons need to be careful about reducing and repairing these large hernias, because the acute increase in abdominal pressure can lead to pulmonary failure and reduced venous return, resulting in an effective abdominal compartment syndrome. 141 Peristomal hernias often interfere with ostomy function and the fit of appliances. This can lead to leakage of stool that can be incapacitating. Prolapse of the bowel through the stoma can occur. This results in the stoma protruding as a proboscis at times. The patient may bring in pictures of an exgorged and protruding stoma that is the prolapsed bowel. Incarceration and strangulation of bowel may occur within the peristomal defect, presenting as a bowel obstruction. 136 Trocar site hernias usually cause pain and a bulge at the trocar site. Because of the small opening, it is more likely intra-abdominal contents could become strangulated in the defect. Richter hernia has been reported, and other organs, e.g., stomach, can herniate into trocar hernias. 142,143 Diagnosis of an incisional hernia can be difficult if the defect is small, tender, or in an obese patient. A useful adjunct to diagnosis can be ultrasound or CT. The physician requesting the ultrasound or CT should carefully communicate his or her suspicions to the radiologist, because specific maneuvers can be performed by the radiologist to demonstrate the defect. For example, ultrasound can be performed with the patient in an upright position or CT in the prone position. 144 Peristomal hernias can also be identified with intrastomal ultrasound. 145 Although CT is the diagnostic modality of choice, trocar site hernias are especially challenging to diagnose, as the site of facial entry can be tangential to the skin incision site. This is because the abdomen is insufflated with carbon dioxide at the time of trocar placement, leading to different facial entry point than when the abdomen is desufflated. The finding of localized pain at a site that is close to a trocar site should trigger evaluation with CT scan. Treatment and prognosis: incisional hernias are best repaired with prosthetic mesh. The recurrence rate is substantially lower than after traditional tissue repair. 135 Synthetic mesh and biologic mesh, which provides a tissue matrix into which ingrowth occurs with remolding, are available for use. The key element in hernia repair is to achieve a tension-free repair. In general, every attempt should be made to bring the fascia together with an underlay of mesh underneath the fascia to reinforce the repair. In fact, the term abdominal wall reconstruction has been coined as a better description for this type of surgery. This term emphasizes the attempt to restore anatomy, with medialization of the components of the abdominal wall. The trend has been toward restoring anatomy whenever possible. Every attempt is made to place a layer of peritoneum or hernia sac between the abdominal contents and the mesh. However, if this cannot be done, special double-sided mesh is available with a barrier of some kind on one side, to prevent adhesions to viscera. This material does not stick to bowel and is therefore unlikely to erode into the intestine. 141 There has been a trend toward using biological mesh in patients who are high risk for poor wound healing, such as patients with obesity, diabetes, or a smoking history. If diaphragmatic dysfunction, event ration disease, is suspected, the abdominal wall may have to be stretched by repeated progressive pneumoperitoneum before repair. 146 Recurrences of incisional hernia are reported in 2% to 60% of cases, depending on the method used for repair and the duration of follow-up. 139, 147, 148 Minimally invasive repair of ventral defects can be performed. There is some suggestion that minimally invasive repair results in fewer recurrences and lower morbidity. 135, 147 Minimally invasive hernia repair is performed by insufflating the abdomen and gradually creating a working space by carefully lysing adhesions. Double-sided mesh is then placed in the retroperitoneal position and fixed by tacks and sutures. This approach effectively bridges the gap rather than medializing the hernia edges. This can result in the sensation of a residual hernia, caused by retention of fluid in the hernia sac between the mesh and the skin, which can be frustrating for the clinician and patient. In contrast to open repairs, the fascia is not brought together in minimally invasive hernia repair, and therefore the patient will have a persistent bulge in the area of the hernia. This is due to the lack of abdominal musculature within the hernia defect itself, which contains only mesh. Some surgeons perform a minimally invasive components separation, where the lateral components are incised and slide to meet at the midline. This can be performed minimally invasively and can result in no bridging with mesh, and hence no bulge. Chronic pain at suture or tack sites appears to be a greater issue with laparoscopic hernia repair than with open repair. 149,150 Small and minimally symptomatic peristomal hernias may be treated with a modified ostomy belt. If surgery is necessary, there are several modes of treatment. The best treatment is to eliminate the stoma completely. This requires the ability to reconstruct the patient, an option not possible in the patient who has undergone abdominoperineal resection. The stoma can be relocated to the other side or another quadrant of the abdomen. Primary repair of the peristomal defect is no longer considered adequate treatment, mesh placement is advocated. A piece of mesh shaped with a keyhole defect through which the stoma can be exteriorized can be used. 136 Alternatively, the sugar baker technique can be performed, where a flat piece of mesh is placed over the piece of bowel as it exits for the stoma. This changes the angle of the bowel to parallel to the abdominal wall and creates a physiologic effect preventing future hernia formation. Important for the gastroenterologist to know in this case is that the scope will travel parallel to the abdominal wall before diving into the abdomen. These repairs can all be performed minimally invasively. 151,152 To decrease the incidence of trocar site hernias, it is recommended that trocar ports be removed under direct vision and the defects sutured closed, particularly those defects related to trocars larger than 10 mm in diameter. Newer prosthetic materials with biological components are now available. These biological meshes can be used in place of mesh in patients in whom there has been contamination, such as when bowel resection is necessary. The mesh substrates are thought to be degradable over time. After implantation, it is thought that they cause an influx of fibroblasts, resulting in a vigorous scar that can provide strength similar to mesh. With time, biological mesh degrades, leaving only autologous tissue. This is called tissue ingrowth and remolding. However, hernia chapter 27 abdominal hernias and gastric volvulus 393-27 recurrence is still a significant issue and can occur in up to 21% of patients. 153 Because of the significant recurrence rate, bridging of defects should be avoided when using biological mesh. Epigastric and umbilical hernias. Etiology and pathophysiology. Epigastric hernias occur through midline defects in the aponeurosis of the rectus sheath, linea alba, between the xiphoid and umbilicus. These defects are usually small and frequently multiple. Because of the location in the upper part of the abdominal wall, it is unusual for bowel to become incarcerated in epigastric hernias. The falciform ligament lies in this location, providing protection for bowel incarceration. More commonly, preperitoneal fat or omentum protrude through these hernias. 154 Umbilical hernias in infants are congenital, see Chapter 98. They often close spontaneously. There is an increased incidence of congenital umbilical hernias in children of African descent. 155 In general, these defects will close spontaneously by 4 years of age. 156 If they are still evident after this age, surgical repair is indicated. In adults, umbilical hernias may develop consequent to increased intra-abdominal pressure due to ascites, pregnancy, or obesity. Epidemiology. Epigastric hernias are found in 0.5% to 10% of autopsies. 154 Many are asymptomatic or undiagnosed during life. They generally occur in the 3rd through 5th decades. Risk factors for epigastric hernia include obesity, smoking, and heavy lifting. 154 Epigastric hernia has also been reported after deep inferior epigastric perforator, deep, flap breast reconstruction. 157 Umbilical hernias occur in about 30% of African American infants and 4% of white infants at birth, and are present in 13% and 2%, respectively, by 1 year of age. 158 Umbilical hernias are more common in low birth weight infants than in those of normal weight. Other risk factors include obesity and pregnancy. Umbilical hernias occur in roughly 20% of patients with cirrhosis and ascites. 159 Clinical features, diagnosis, and complications. The main symptom of epigastric hernia is upper abdominal pain, usually localized to the abdominal wall, rather than the deep visceral pain that accompanies intestinal pathology. A specific tender nodule or point of tenderness can be palpated in the non-obese patient. Diagnosis may be difficult, particularly in obese patients. However, symptoms are sometimes mistaken for those of a peptic ulcer or biliary disease. Determining that the discomfort is in the abdominal wall, rather than deep within the peritoneum, can help distinguish incarcerated bowel from fat in the hernia. Sonography and CT may be helpful in the diagnosis. 160,161 Complications of epigastric hernia are very rare, with reports of acute pancreatitis from incarceration of the head of the pancreas, perforation of a gastroduodenal ulcer incarcerated in the hernia, and strangulation of bowel in the hernia. 162-164 Umbilical hernias in children are usually asymptomatic. Adults may be asymptomatic or report some discomfort with palpation of the hernia. Incarceration and strangulation may occur in children and adults. Spontaneous rupture of umbilical hernias may occur in patients with ascites and, rarely, in pregnant women. 165,166 Skin changes with maceration and ulceration generally occur prior to frank rupture. Therefore, the findings of skin changes in a patient with an umbilical hernia should warrant urgent repair. Care must be taken when performing a therapeutic paracentesis in patients with umbilical hernias. The hernia must be reduced and kept reduced during the paracentesis, because strangulation of umbilical hernias may occasionally be precipitated by rapid removal of ascites. 159,167 Treatment and prognosis. If surgery is performed for epigastric hernia, the linea alba should be widely exposed because multiple defects called Swiss cheese defects may be found. A minimally invasive approach is preferred in this circumstance, where excellent visualization of the midline can be achieved with just a few 5 mm ports. A single defect can be fixed easily, and a Swiss cheese type scenario can also be fixed minimally invasively without opening the whole midline of the abdomen. Mesh is laid within the abdomen to cover all of these defects. Surgical repair is typically successful, with a low recurrence rate. Umbilical hernias are most often left untreated in children. Complications are unusual, and they usually close spontaneously if smaller than 1.5 cm in diameter. Repair should be considered if they are larger than 2 cm or if they are still present after 4 years of age. 158 Repair of umbilical hernias should be recommended for adults if they are difficult to reduce or symptomatic. Techniques for repair of all abdominal wall defects rely on a tension-free repair to decrease the risk of recurrence. Open or minimally invasive techniques can be used to achieve this end. 168 Data support routine use of mesh in repair of these defects, because this results in a decrease in recurrences. 169 Mesh is always used in minimally invasive repair. When complications develop in patients with umbilical hernias, the prognosis worsens significantly. Those patients requiring bowel resection at the time of umbilical herniorrhaphy or who have ascites and cirrhosis have increased mortality. 167,170 Repair of umbilical hernias in patients with cirrhosis and ascites is a difficult clinical problem. In general, ascites should be aggressively controlled. If this is not possible, consideration should be given to TIPS or liver transplantation, see chapters 93 and 97. Spontaneous rupture of umbilical defects in patients with ascites portends a poor prognosis, with reported mortality rates of up to 60%. 159,165,171 Minimally invasive techniques and earlier repair of hernias in patients with cirrhosis should be considered, although acidic leak from even a trocar site can be fatal. The morbidity of elective repair appears not to be as high as once thought, with a recent trial reporting a mortality rate of 3.7% for elective repair, with even lower rates, 1.3%, for patients with a MELD score less than 15.172. Outcome after surgical repair is directly dependent on nutritional status and control of ascites. Control of ascites may require frequent paracentesis to keep the abdomen flat to allow healing. Topical fibrin sealant has been used to successfully treat a leaking umbilical hernia in a patient with ascites. 173. In general, one should undertake umbilical hernia repair with caution in cirrhotic patients with ascites. This would be a circumstance where liver transplantation evaluation prior to hernia repair would be prudent. Spigelian hernias. Etiology and pathophysiology. Spigelian hernias occur through defects in the fused aponeurosis of the transversus abdominis muscle and internal oblique muscle, lateral to the rectus sheath. They most commonly occur just below the level of the umbilicus, see Fig 27.7. This area is called the Spigelian fascia, named after the Belgian anatomist Adriaan van den Spiegel. This fascia is where the linea semilunaris, the level at which the transversus abdominis muscle becomes aponeurosis rather than muscle, meets the semicircular line of Douglas. The epigastric vessels penetrate the rectus sheath in this area. The combination of all these anatomic features can lead to a potential defect in a Spigelian hernia. The Spigelian fascia is covered by the external oblique muscle, and therefore, Spigelian hernias do. 394. Part 4. Topics involving multiple organs not penetrate through all layers of the abdominal wall, making the diagnosis of a hernia challenging. 156. Epidemiology. Spigelian hernias are very rare. Only about 1,000 cases have been reported. 174. The largest series of patients included 81 patients. 175. They are twice as common in females as in males and are somewhat more common on the left side of the abdomen. 176, 177. They generally occur in patients around age 60 years. 175-177. Clinical features, diagnosis, and complications. Spigelian hernias can be difficult to diagnose because the external oblique muscle overlies the defect in the deeper fascia. Only 75% to 80% of patients with a Spigelian hernia are correctly diagnosed before surgery. 175-177. The examiner must have a high degree of suspicion when a patient complains of pain at the lateral edge of the rectus, inferior to the umbilicus. Careful examination will suggest that the pain originates in the abdominal wall and not in the peritoneal cavity. This determination is critical because a Spigelian hernia can be mistaken for conditions like acute appendicitis and diverticulitis. 178-180. Frequently, only omentum is present in the hernia, but large or small bowel, ovary, appendix, or fallopian tube may herniate. 175-179-181. A Richter hernia or a bowel obstruction caused by incarcerated small intestine may occur. 182. The differential diagnosis includes rectus sheath hematoma, lipoma, or sarcoma. Sonography and CT are the most useful adjuncts for diagnosing a Spigelian hernia. 175-177-183. An astute radiologist will perform these studies using various techniques, e.g., Valsalva maneuver, to increase detection of even a small Spigelian hernia. The finding of a viscera structure penetrating through the two inner layers of the abdominal wall at the correct location will lead to the diagnosis of a Spigelian hernia. Treatment and prognosis. Spigelian hernias may be approached by open or minimally invasive techniques. 184-185. Laparoscopy can be helpful as a diagnostic tool in patients suspected of having a Spigelian hernia, even if open repair is anticipated. 186. The hernia can be best identified from within the peritoneal cavity. Preperitoneal laparoscopic techniques can be used, with the advantage of staying outside the peritoneal cavity, thereby avoiding adhesions. 185. Intraperitoneal laparoscopic repair can be performed using mesh that is coated on one side so as not to stick to the underlying bowel. 185-187. Minimally invasive approaches result in decreased pain and decreased length of hospital stay compared with open techniques. 188. However, these hernias are so rare, the surgeon's choice of technique should be based on personal experience. It is the author's preference to at least start with a laparoscopic approach, as this can confirm the diagnosis and help locate the hernia itself. As with other hernias, most Spigelian hernias are closed using mesh repairs, a technique that appears to have a lower recurrence rate than primary repair. 175-185. Pelvic and perineal hernias. The three main types of pelvic and perineal hernias are obturator, sciatic, and perineal hernias. Etiology and pathogenesis. Obturator hernias are rare and occur in older women, and thus are sometimes called little old lady's hernia. 189 Obturator hernias occur through the greater and lesser obturator foramina. The obturator foramen is larger in women than in men and is ordinarily filled with fat. Marked weight loss predisposes to herniation. 190 Sciatic hernias occur through the foramina formed by the sciatic notch and the sacrospinous or sacrotuberous ligaments. Abnormal development or atrophy of the piriform muscle may predispose to sciatic hernia. Sciatic hernias may contain ovary, ureter, bladder, or large or small bowel. 191 Perineal hernias occur in the soft tissues of the perineum and are very rare. They may be primary or postoperative. Primary perineal hernias occur anteriorly through the urogenital diaphragm or posteriorly through the levator ani muscle or between the levator ani and coccygeus muscles. Secondary perineal hernias occur most often after surgery, such as abdominal perineal resection, pelvic exenteration, or hysterectomy. 192-194 Radiation therapy, wound infection, and obesity predispose to the development of secondary perineal hernias. 195-196 Epidemiology Obturator hernias typically occur in older, cachectic, multiparous women. About 800 cases have been reported. 197 In Asia, obturator hernias account for about 1% of all hernia repairs, but in the West, they account for 0.07% of all hernias. 198-199 Sciatic hernias are even less common than obturator hernias, with fewer than 100 cases reported. 191 They are most common in older women, although are occasionally seen in children. 200 Perineal hernias are also rare. Primary perineal hernias are most common in middle-aged women. Secondary perineal hernias occur after less than 3% of pelvic exenterations and less than 1% of abdominal perineal resections for rectosigmoid cancer. 196-201 Clinical features, diagnosis, and complications. Obturator hernias occur almost exclusively in older women and are more common on the right side. 197-202 They commonly cause cramping, lower abdominal pain, nausea, and vomiting. Almost all patients present with symptoms of small bowel obstruction. 202 Because the hernia orifice is small, Richter hernia and strangulation are common, and bowel necrosis is not uncommon. 202-203 There are three signs specific for an incarcerated obturator hernia. 202 The first is obturator neuralgia, manifesting as paresthesia that extends along the medial aspect of the thigh. Second is the Hausche-Bromberg sign, caused by pressure on the obturator nerve and resulting in paresthesias and pain in the hip and inner thigh. The pain is diminished by hip flexion and increased by hip extension, adduction, or medial rotation. This sign is seen in 25% to 50% of patients with obturator hernia and is considered pathognomonic. Third is the Hannington-Kiff sign, elicited by percussing the adductor muscle above the knee. Absence of the normal adductor reflex contraction is a strong indicator of obturator nerve impingement caused by an obturator hernia. Occasionally a mass may be palpable in the upper medial thigh or in the pelvis on pelvic or rectal examination. The diagnosis is difficult, often delayed, and usually not made preoperatively. The treating physician must have a low threshold for entertaining this diagnosis in an elderly cachectic female patient with a bowel obstruction in the pelvis. Preoperative diagnosis is sometimes evident on ultrasound or CT. 202-204-205 Sciatic foramen hernias may manifest as a mass or swelling in the gluteal or infragluteal area, but are generally difficult to palpate because they occur deep to the gluteal muscles. Chronic pelvic pain caused by incarceration of a fallopian tube and/or ovary may occur. 206 Impingement on the sciatic nerve may also produce pain deep in the buttock or radiating to the thigh. 207 Intestinal or ureteral obstruction may occur. The differential diagnosis includes lipoma or other soft tissue tumor, cyst, abscess, and aneurysm. 208 The diagnosis is often difficult, with only 37% of patients diagnosed by physical exam findings. 191 CT and MRI Chapter 27 Abdominal hernias and gastric volvulus 395-27 may be helpful, but many patients are diagnosed at laparotomy or laparoscopy. In women, primary perineal hernias manifest anteriorly in the labia majora, pudendal hernia, or posteriorly in the vagina. 195 In men, they manifest in the ischiorectal fossa. Primary and postoperative perineal hernias are usually soft and reducible. Most patients complain of a mass that produces discomfort on sitting. Because the orifice of the hernia is usually wide, incarceration is rare. If the bladder is involved, urinary symptoms may occur. 209 Postoperative perineal hernias may be complicated by cutaneous ulceration. The differential diagnosis includes sciatic hernia, tumor, hematoma, cyst, abscess, and rectal or bladder prolapse. 210 Treatment and prognosis. The treatment of pelvic hernias is surgical. Laparoscopic repair of obturator, sciatic, and perineal hernias has been reported. 192, 211, 212 However, most patients with pelvic hernias present with an acute surgical condition, often bowel obstruction, and it is often necessary to perform an open procedure to manage the problem. Repair of perineal hernias can be complex. When bowel resection is required, mesh placement is usually not used because of the high risk of infection. The advent of biologic products has allowed these materials to be used in contaminated fields. 191 Peritoneal flaps or muscle advancement flaps can be used to perform tissue repairs of these defects. 213 The prognosis is poor when patients present with an acute illness, and is more related to the underlying medical conditions rather than the hernia itself. Nutritional depletion, advanced age, and poor medical health are all confounding variables. Lumbar hernias etiology and pathophysiology. Lumbar hernias can occur in two separate triangular areas of the flank. The superior triangle, Grinfeld lumbar triangle, is bounded by the 12th rib superiorly, the internal oblique muscle inferiorly, and the sacrospinous muscles medially. The inferior triangle, Petit lumbar triangle, is bounded by the latissimus dorsi muscle posteriorly, the external oblique muscle anteriorly, and the iliac crest inferiorly. Fig 27.9. 214 Grinfeld hernias are more common than Petit hernias. Lumbar hernias are more common on the left than on the right side. This may be because the liver pushes the right kidney inferiorly in development, leading to protection of the lumbar triangles. Pseudohernia may occur in the lumbar area as the result of paresis of the thoracodorsal nerves. 215, 216 This is caused by loss of muscle control and tone, but there is no associated facial defect. Causes of pseudohernia include diabetic neuropathy, herpes zoster infection, nerve injury, and syringomyelia. 217 Of the acquired lumbar hernias, about half are spontaneous and the rest are incisional or post-traumatic hernias. Flank incisions are used to access the retroperitoneum for procedures such as nephrectomy, and hernias can result, which may be true hernias or pseudohernias caused by postoperative muscle paralysis. 218, 219 Lumbar hernias have also been reported after harvest of bone from the iliac crest. 220 Motor vehicle accidents are the most common cause of post-traumatic lumbar hernias. If a lumbar hernia is found after a motor vehicle accident, it is critical to assume that the patient has other intra-abdominal injuries. Most of these patients will undergo urgent laparotomy. More than 60% of them will have major intra-abdominal injuries. 221, 222 Epidemiology. Lumbar hernias are rare, with about 300 cases reported. 215 Some 20% are congenital, and they are rarely bilateral. 223, 224 Clinical features, diagnosis, and complications. Lumbar incisional hernias generally present as a large bulge that may produce discomfort. These are especially evident when the patient strains or is in the upright position. Because of the large size of the defect, incarceration is not common. Moreover, the location, in the retroperitoneum, makes incarceration of intra-abdominal structures rare. Superior and inferior lumbar triangle hernias may occur through small defects and can manifest with incarceration, 24%, and strangulation, 18%. 225 The differential diagnosis includes lipoma, renal tumor, abscess, and hematoma. Bowel, mesentery, spleen, ovary, and kidney have been reported to herniate. 223 Occasionally a small lumbar hernia may impinge on a cutaneous branch of a lumbosacral nerve, causing pain referred to the groin or thigh. CT may aid in the diagnosis. 226 Treatment and prognosis. Closure of large lumbar hernias, as well as superior and inferior lumbar triangle hernias, often requires the use of prosthetic mesh or an aponeurotic flap. These can be challenging cases. Identifying fascia with good tensile strength and repairing the defect with mesh in a tension-free manner is critical to preventing recurrence. 223,227 Fixation of mesh to bony structures, e.g., rib, iliac crest, may be required. Preperitoneal as well as transperitoneal laparoscopic repair has been reported and can result in less pain and quicker return to activity. 215,219,228,229 Large and symptomatic lumbar pseudohernias should be treated by managing the underlying condition. Resolution has been reported following treatment of herpes zoster. 217 Internal hernias. Internal hernias are protrusions into pouches or openings within the abdominal cavity, rather than through the abdominal wall. Internal hernias may be the result of developmental anomalies or may be acquired. 230 Commonly, internal hernias develop after earlier abdominal surgery, such as after an RYGB procedure. 12th rib. Internal oblique sacrospinalis iliac crest. External oblique latissimus dorsi. Fig 27.9 Anatomic diagram of lumbar hernias. The inferior triangle hernia, petit hernia, thick arrow, is bounded by the latissimus dorsi muscle, the external oblique muscle, and the iliac crest. The superior triangle hernia, Grunfeld hernia, thin arrow, is bounded by the 12th rib, the internal oblique muscle, and the sacrospinalis muscle. 396 Part 4 Topics involving multiple organs. Etiology and pathophysiology. Internal hernias caused by developmental anomalies include paraduodenal, foramen of Winslow, mesenteric, and supravesical hernias. During gestation, the intestines are extra-abdominal. During fetal development, the mesentery of the duodenum, ascending colon and descending colon becomes fixed to the posterior peritoneum. These segments of the bowel become reperitonealized and attached to the retroperitoneum. Anomalies of mesenteric fixation may lead to abnormal openings through which internal hernias may occur. The extreme example of this is a complete intestinal malrotation, in which the ligament of Treitz does not assume its appropriate location to the left of the spine. This condition predisposes to midgut volvulus and can lead to extensive mesenteric ischemia. See Chapter 98. 231,232 Lesser anomalies of fixation lead to defects such as paraduodenal and supravesical hernias. Abnormal mesenteric fixation may lead to abnormal mobility of the small bowel and right colon, which facilitates herniation. During fetal development, abnormal openings may occur in the pericecal, small bowel, transverse colon, or sigmoid mesentery, as well as the omentum, leading to mesenteric hernias. 230 Unusual hernias can occur on structures like the broad ligament. 233 Abnormal fixation of the mesentery of the descending or ascending colon may lead to paraduodenal hernias. Paraduodenal hernias occur on the left side in 75% of cases and have a 3:1 male predominance. 234,235-237 Patients most commonly present in the fourth decade. In cases of left paraduodenal hernia, an abnormal foramen, the fossa of Lanzert, occurs through the mesentery close to the ligament of Treitz, leading under the distal transverse and descending colon, posterior to the superior mesenteric artery. Small bowel may protrude through this fossa and become fixed in the left upper quadrant of the abdomen. The mesentery of the colon thus forms the anterior wall of a sac that encloses a portion of the small intestine. Right paraduodenal hernia occurs in the same fashion through another abnormal foramen, the fossa of Waldeyer, leading under the ascending colon. 230-238 Foramen of Winslow hernias may occur when this foramen is abnormally large, particularly if there is abnormal mesenteric fixation of the small bowel and right colon. Most commonly, the right colon is abnormally fixed to the retroperitoneum, resulting in a patulous foramen of Winslow. Abnormally mobile small bowel and colon may herniate through the foramen of Winslow into the lesser sac. Symptoms of small bowel or colonic obstruction may occur, and these may be intermittent as the hernia reduces spontaneously. Impingement on the portal structures can occur but rarely results in biliary obstruction or compression of the portal vein. 239,240 Gastric symptoms may also occur if the herniated bowel becomes distended, because the herniated bowel loops are located in the lesser sac, behind the stomach. Mesenteric hernias occur when a loop of intestine protrudes through an abnormal opening in the mesentery of the small bowel or colon. These mesenteric defects are thought to be developmental in origin, although they may also be acquired as a result of surgery, trauma, or infection. The most common area for such an opening is in the mesentery of the small intestine, most often near the ileocolic junction. Defects have been reported in the mesentery of the appendix, sigmoid colon, and amecal diverticulum. 241-243. The intestine finds its way through the defects through normal peristaltic activity. Various lengths of intestine may herniate posteriorly to the right colon into the right paracolic gutter, Fig 27.10. Compression of the loops may lead to obstruction of the herniated intestine. Strangulation may occur by compression or by torsion of the herniated segment. Obstruction may be acute, chronic, or intermittent. The herniated bowel may also compress arteries in the margins of the mesenteric defect, causing ischemia of non-herniated intestine. Similar defects may occur in the mesentery of the small bowel, transverse mesocolon, omentum, and sigmoid mesocolon. There are 3 types of mesenteric hernias involving the sigmoid colon. Transmesosigmoid hernias have no true sac. They occur through both layers of the mesocolon. Generally, the bowel becomes trapped in the left gutter, lateral to the sigmoid colon. Intermesosigmoid hernias are hernias that occur within the leaves of the sigmoid colon. This results in the hernia contents being contained within the mesentery of the sigmoid colon, generally posterior to the sigmoid colon. Intersigmoid hernias occur between the retroperitoneal fusion plane, between the sigmoid colon mesentery and the retroperitoneum. These hernias are contained in the retroperitoneum and generally lift and dissect the sigmoid colon on its mesentery out of the left gutter. 236. Supravesical hernias protrude into abnormal fossae around the bladder. They are classified as internal or external supravesical hernias. Internal supravesical hernias occur within the abdomen and thus are internal hernias. They may extend anterior, lateral, or posterior to the bladder. External supravesical hernias occur outside the abdominal wall and appear much like indirect inguinal hernias. They usually contain small bowel but may contain omentum, colon, ovary, or fallopian tube. 244-246. Acquired internal hernias may occur as a complication of surgery or trauma if abnormal spaces or mesenteric defects are created. Adhesions can create spaces into which bowel may herniate. Division of mesentery to create conduits, such as Roux-en-Y limbs, can lead to defects within the mesentery or around the reconstruction, which can result in herniation. With the increased popularity of the RYGB procedure for morbid obesity, there has been an increased incidence of unusual hernias related specifically to this surgery, discussed later. 247-248-249. Retroanastomotic hernias may occur after gastrojejunostomy, colostomy, or ileostomy, ileal bypass, or vascular bypass when an abnormal space may be created into which small bowel, colon, or omentum may herniate. Retroanastomotic hernia can occur after gastrojejunostomy, usually after gastric resection with Bill-Rote 2 reconstruction. The afferent loop, or both, protrude into the space posterior to the anastomosis. Efferent loop hernias are about 3 times as common as afferent loop hernias, likely caused by the limited length of the afferent loop and the tethering effect of fixed structures involved in the afferent loop. For example, after a Bill-Rote 2 anastomosis, the afferent loop is connected to the duodenum, which is fixed, and the efferent loop is connected to the remainder of the small intestine. The efferent loop is therefore more mobile and can herniate into potential spaces. 236-250. Colostomy, ileostomy, ileal bypass, and vascular bypass procedures may also lead to the creation of a space into Fig 27.10 CT of an internal, pericecal, hernia with strangulation. A mass of infarcted small intestine is seen in the right side of the abdomen, white arrow. The area of herniation, open arrow to right of spine, shows twisting of the small bowel as it passes through the mesentery. Courtesy Dr. Michael J. Smarud, Dallas, Texas. Chapter 27. Abdominal hernias and gastric volvulus. 397-27. Which organs can protrude? Obstruction secondary to retroanastomotic hernia has been reported after liver transplantation. 251 Renal transplant procedures are extraperitoneal, but an unrecognized inadvertent rent in the peritoneum can lead to pararenal intestinal herniation. 252 Hernias after RYGB procedures have become more common with the increasing demand for this operation. These can be internal or external hernias through the incision or port sites. Small bowel obstruction related to internal hernias after RYGB occurs in 2% to 3% of patients. 247, 248, 253 There are three potential spaces created during the RYGB that can result in internal herniation. The Peterson defect occurs to the right of the jejunum as it traverses the mesentery of the transverse colon to reach the pouch of the stapled stomach. By definition, the roux limb has to travel in the retrocolic location for this to occur. The endoscopist encounters this as a narrowing that occurs in the roux limb at around 40 to 60 cm distal to the pouch jejunum anastomosis. The jejunojejunostomy mesenteric defect occurs between the divided leaves of the small intestinal mesentery. The mesentery is divided to create the roux limb, which is brought up to the gastric pouch. The two edges of the transected mesentery are then sewn together to prevent this defect. However, despite these measures, a defect can develop resulting in herniation of intra-abdominal contents. The transverse mesocolic defect occurs through the defect in the transverse mesocolon through which the jejunal limb is brought to reach the stomach pouch. The Peterson and transverse mesocolic defects can be avoided by placing the jejunal limb in an anticolic position. In this case, the jejunum is not placed through a rent in the transverse mesocolon, but rather is brought anterior to the transverse colon. Although this makes intuitive sense, it is not always possible to achieve enough length of small intestinal mesentery to ensure an anticolic anastomosis without tension. With the majority of RYGB being performed laparoscopic, there are fewer adhesions being formed after surgery. This in fact allows for greater mobility of the small intestine and a greater ability to prolapse through hernia defects. Adhesions with open surgery can actually reduce the risk for this type of internal hernia. However, adhesive causes for bowel obstruction occur more frequently in the open gastric bypass cases. Hernias can occur in the mesentery of the colon very rarely after colonoscopy. 254, 255 This likely occurs as a rent develops in the sigmoid mesocolon with insufflation of the colon. Hernias may occur through the broad ligament of the uterus, most commonly through tears occurring during pregnancy, because the majority of these hernias occur in Paris women. Other cases may be developmental or caused by surgery. 233, 256 Epidemiology Internal hernias are rare and occur most often in adults. They are found in 0.2% to 0.9% of autopsies, but a substantial proportion of these remain asymptomatic. 236 About 5% of bowel obstructions are caused by internal hernias. Although half of developmental internal hernias are paraduodenal hernias, 1% or fewer of all cases of intestinal obstruction are caused by paraduodenal hernias. 232-37, 257 They are more common in males than in females. They may occur in children or adults but typically manifest between the 3rd and 6th decades of life. Most, 75%, paraduodenal hernias occur on the left side. 234-237 Foramen of Winslow hernias are very rare, accounting for 8% of internal hernias. 232-57 Mesenteric hernias are rare and can occur at any age. 236-250 Supravesical hernias are extremely rare, with limited case reports. They are more common in men than in women. Almost all reported cases have occurred in adults, most commonly in the 6th or 7th decade. 246 Similarly, broad ligament hernias are exceedingly rare. 233 Post-gastroenterostomy internal hernias have become less common because the frequency of surgery for peptic ulcer disease has declined. Other post-anastomotic internal hernias are also rare. 236 Internal hernias related to RYGB procedures have become more common because surgeries for morbid obesity have become more widely performed. Small bowel obstruction related to internal hernias in most patients occurs with an incidence of 2% to 3% after RYGB.247,248,253. Clinical features and diagnosis. Any of the various forms of internal hernias may manifest with symptoms of acute or chronic intermittent intestinal obstruction. The diagnosis is difficult in patients with chronic symptoms and is rarely made preoperatively in patients who present with acute obstruction and strangulation. 230-236,250 intestinal obstruction, which may be low-grade, chronic, and recurrent, or high-grade and acute, develops in about half of patients with paraduodenal hernias. 236,237 UGI tract contrast radiography has been shown to have excellent accuracy. Barium radiographs may show the small bowel to be bunched up or agglomerated as if it were contained in a bag, and displaced to the left or right side of the colon. Small bowel is often absent from the pelvis, and appears to be present in the lesser sac, posterior to the stomach. The colon may be deviated by the internal hernia sac. Bowel proximal to the hernia may be dilated. 236,258 However, barium radiographs may be normal if the hernia has reduced at the time of the study. Endoscopy is not reliable for the diagnosis of paraduodenal hernias. Displacement of the mesenteric vessels can be noted if CT with intravenous contrast or arteriography is performed. 234,236 However, CT may miss a paraduodenal hernia unless specific attention is paid to the relationship of the small intestine to the colon and mesenteric vessels. In hernias of the foramen of Winslow, small bowel herniates behind the portal structures in about 2/3 of cases. In the remaining cases, the right colon herniates into the lesser sac. Herniation of the gallbladder has been reported. 239 Patients may have symptoms of gastric or proximal intestinal obstruction, even in the case of colon herniation, because of pressure of the herniated bowel on the stomach. Occasionally, an epigastric mass is palpable. Plain abdominal radiographs may show the stomach displaced anteriorly and to the left. Bowel, most commonly right colon, will be seen posterior to the stomach in the lesser sac. Contrast enema may show displacement of the cecum into the epigastrium. CT is accurate for the diagnosis of foramen of Winslow hernias. The herniated bowel is posterior to the stomach within the lesser sac. There may be associated dilation of the biliary tree or portal vein narrowing caused by compression of the portal structures. Rarely is there any physiologic consequence to this finding. 236,240 Mesenteric hernias are difficult to diagnose preoperatively. Symptoms and signs are those of acute or chronic intermittent bowel obstruction or acute strangulation. 250 Plain abdominal radiographs may show evidence of bowel obstruction or displacement of the normal gas pattern. For example, with hernias through the sigmoid mesentery, the small intestine gas pattern lies laterally to the sigmoid gas pattern. 236 This finding, in association with bowel obstruction, may increase the suspicion for an internal hernia. Internal supravesical hernias produce symptoms of bowel obstruction. Associated symptoms of bladder compression occur in about 30% of cases. Anterior supravesical hernias may result in a suprapubic mass or tenderness. Patients with supravesical hernia may also have an inguinal hernia. Barium radiography or abdominal CT with oral contrast may be helpful in the diagnosis. 244,246 Hernias of the broad ligament of the uterus cause symptoms of bowel obstruction in about half of cases and can cause chronic pelvic pain. 256 Other cases are discovered incidentally at surgery. Small bowel, sigmoid colon, appendix, omentum, and ureter have been reported to herniate. CT scanning may show dilation of small bowel and deviation of the uterus. 398 Part 4 Topics involving multiple organs. Retroanastomotic hernias cause symptoms and signs similar to those of other internal hernias. Postgastrojejunostomy hernias cause symptoms of gastric outlet obstruction. The efferent loop herniates most often. Afferent loop hernias are a cause of the afferent loop syndrome. See Chapter 53. About 50% of postgastrojejunostomy hernias occur within the first month after surgery, 25% occur during the first year, and the rest occur later. 257 The physical examination is not specific. The serum amylase and lipase level is often elevated with afferent limb obstruction. Plain abdominal radiographs may show gastric distension in a fluid-filled loop. Barium UGI radiographs are most useful for documenting efferent limb obstruction versus afferent limb obstruction. Sonography or CT may show dilation of the afferent limb, or the whorl sign, where the mesenteric vessels and small bowel appear to twist around a point 259, Fig. 27.11. Biliary scintigraphy will show excretion of radionuclide into the biliary tree but retention of the tracer in an obstructed afferent limb. 236. The clinical presentation of post-RYGB hernias is similar to that of other internal hernias. Most commonly, bowel obstruction is present. Herniation of the afferent limb of the jejunojejunostomy, the limb that carries pancreaticobiliary secretions, can present an interesting diagnostic dilemma because this loop does not carry food material. Therefore, vomiting may not occur. As a consequence, herniation of the afferent limb may present with biliary obstruction and pancreatitis rather than classic bowel obstruction. CT and plain films will show evidence of duodenal distension, and on biliary scintigraphy there is lack of progression of radionuclide from the dilated duodenum into the distal small intestine. Herniation of the distal small intestine manifests with signs and symptoms of a bowel obstruction. The finding of a whorl sign after RYGB in a patient with symptoms should lead to immediate surgical evaluation. Delay in treatment can result in bowel loss and death. Strictures at the base of the roux limb can present with a similar obstructive syndrome. However, findings of a more distal bowel obstruction should increase suspicion for an internal hernia. Treatment and prognosis. Symptomatic internal hernias require surgery. 230-236, 250-257 Laparoscopic repair is preferred if the hernia is detected prior to complications. 240-246, 256 Once the patient has developed signs and symptoms of bowel obstruction, it is reasonable to explore the patient, reduce the hernia, ensure the bowel is viable, and repair the defect. Acute obstruction leads to strangulation, bowel ischemia, and death if not promptly treated. 243 Paraduodenal hernias are usually corrected by incising the enclosing mesentery. Care must be taken to avoid injuring the superior or inferior mesenteric arteries, because they follow an abnormal course within the border of the hernia. Sometimes the small bowel can be reduced through the opening of the hernia without incising the mesentery. 234-237 Thereafter, the paraduodenal defect must be closed. This may involve performing a formal LAD procedure if the hernia is associated with a true malrotation, see Chapter 98, point 231-232. If there is a patulous paraduodenal space, a simple resection of the hernia sac and placation of the defect can afford adequate repair. Once incarceration has occurred, mortality can be higher than 20%. 237 So it is recommended that all paraduodenal hernias be repaired electively if possible. Broad ligament hernias and supravesical hernias can all be successfully repaired laparoscopic. 233-246-256 Post-RYGB hernias are a common event in the current era, and the gastroenterologist must have a working knowledge of the anatomy and the possible defects that can occur. The post-RYGB patient who is unable to eat may have an internal hernia if there is no obstruction of the pouch jejunal anastomosis. CT will usually show the whorl sign that should alert the treating physician to a possible internal hernia. 259 The surgeon should have a low threshold to operate on these patients, as missing an internal hernia can lead to bowel necrosis and short gut syndrome.